who has been the figure to coordinate this webinar for us. He's a prominent robotic surgeon from Gangaram, and also Dr. Anmol Ahuja. So welcome all of you. And without any further ado, I would request our president of the national body, the Association of Surgeons of India, Dr. P. Raghuram, to give his opening remarks. I was told that he had to leave and would not be able to stay with us for the whole webinar, but I'm very, very happy that he has very kindly agreed to be with us for the opening remarks of this webinar on safe surgery during this pandemic. He has spearheaded so many guidelines from the very beginning, and whatever was being guided from the national headquarters was actually being followed by the government, and many of these suggestions were incorporated in so many ways in the PM's address, as well as in the way in which the whole services, surgical services were, suspended or were to be curtailed, or guidelines to do them were to be issued. So it's my privilege to welcome Dr. P. Raghuram to open this webinar for all of us.
And I would like to address Professor Pavan Lal as Dear Pavan, who has been a dear friend for the past 25 years. And this beginning, I'd like to first of all, on behalf of the association, extend my warm greetings to all of you. There are so many people who have joined, and some people are perhaps yet to join. Certainly, this is the most unprecedented period in our lifetime, and the association, as Professor Pavan Lal has rightly said, has risen to the occasion. And I think I dare say that no other medical organization has championed so many life-transforming initiatives and activities as we have done. On behalf of all of you, I have appeared on national television on numerous occasions and have represented the association's view. And the highlight over the past 2 months has been the video interaction with our Honorable Prime Minister, where he took notes and in fact mentioned some of the points soon after the video conference during his address to the nation on the 24th of March. So the past 2 months has well and truly been a roller coaster ride for me as a president. Never ever expected that I would be neck deep involved in so many initiatives, and I'd like to pay particular tribute here to our past president, Professor Arvind Kumar, for his constant advice and support all along, and many of the initiatives when I was undertaking these initiatives, he was actually advising me. So credit must be given where it is due. And also to Dr. Tarun Mittal, I have very fond memories of very recently coming to your beautiful city and delivering the most prestigious Professor K.C. Mahachan. I will never forget this, in my lifetime, and Dr. Tarun made it so special. So with these few words, I'd like to say how happy I am that you are undertaking this edition, and back to back with the consensus document that Association of Surgeons of India has published, has brought out. And just as we speak today, we have submitted this document for a publication in the June issue of June 2030. And it's great that you are taking this up and discussing and empowering the surgical fraternity. So before I close, I just like to highlight a couple of points. The first and foremost is that the association has started off the year 2020 keeping trainees in mind, because they are not only the future of the association, they are the future of the surgical care community, and many of us will be taken care of by these future surgeons. So for them with the necessary behind the 2020 activities. I'd like to once again express my gratitude to the chief architect of many of these courses for trainees, Dr. Pavan Lal. He has actually already held 5 courses, for the trainees relating to care of the critically ill surgical patient, the communication skills, January, February, and early part of March. And we are back to academics now. We are starting the National Online Skills Enhancement Program, the NSEP, for the postgraduates starting from the 10th of June. Thanks to the hard work, Dr. Santosh John Abraham, who is the director for our academic council, which will seamlessly on to the refresh courses. So the next 3-4 months, we will be seeing a number of online activities for postgraduates. And finally, I'd like to say that as I have written to Professor Pavan Dalal and Dr. Tarun Mittal, I think we are not in any position to meet on and exchange camaraderie. So we have to get on with the online meetings. And I'd like you to explore the possibility of doing your online state chapter congress rather than as a physical meeting where it will not be possible. And I wish you all the best. And finally, I'd say that you will have already received information relating to applying for the various awards, the Pandalaya oration and various other orations which have been advertised on the Indian Journal of Surgery. And for the first time, perhaps in our ASI's history, to ensure transparency, I will be ensuring that the Lifetime Achievement Award begin for the year 2020 will be from the people. It will be a people's nominee, and there will be an award committee that will select this highest award that the association will give to a senior member who has contributed and made substantial, outstanding contribution to surgery and to the art and science of surgery in this country, will be selected in a transparent and robust manner. So I request you will be seeing that information as well on the website soon. So I request all of you, and I'd like you to spread the word down to apply for the various awards, and we will ensure that they are selected. So thank you very much for this opportunity, and all the very best.
Thank you very much, Dr. Raghu, for your all the leadership roles that you have led the association, and we are very grateful for you being here today and for having taken out your time and been a part of this webinar for the Delhi State Chapter of ASI. And you are happy to be a part of us and continue here for the discussion if you have time. But if not, then we thank you, and we look forward to further webinars and opportunities of interacting with the chapter. So with that, I would request, we have a guest surgeon from Bombay, Dr. Raman Goel, who is the president of the Indian Association of Gastroendoscopic Surgeons. And we can just have a few remarks from him before we start the webinar. And then I would request Dr. Tarun to take over and take the proceedings of the seminar forward.
Good evening, everyone. President of ASI, Dr. Raghu, and Dr. Arvind, past president, and all the senior surgeons and colleagues. It's a pleasure to share space with all of you because we remain in our silos. We are all members of respective associations and of each other's association, but still we are working at different levels. And I almost agree with what the ASI is doing with under Dr. Raghu's leadership. Most of the associations are almost doing similar jobs. So I don't want to repeat all that has already been said, supporting the healthcare workers with PPEs, guidelines, publication of guidelines, webinars. They are hallmark of any vibrant association. And we are also starting our well-known fellowship programs like FIAGS, FALS, and all from June. So I think all the associations at a parallel level are working in the same way and are trying to help the surgeons. And I'm glad that this webinar is happening because though everybody keeps saying that there are too many webinars happening, but I still find we are not able to reach each and every surgeon at every corner in the country. So I think there is a need of the hour that we inform them well, because if one surgeon falls sick with the COVID because they did not know, they did not take adequate precautions, then it's our failing. And I think I thank Delhi chapter of ASI for organizing this. I'm aware of the funds they have raised and distributed PPEs through that chapter. So Dr. Pavninder Lal, Dr. Vivek Bindal, Tarun, and other members of Delhi chapter. I see Dr. Srivastava also there. So great job by all of you. Please continue, and I'll be very happy to share. I'm here with you for the duration of the webinar.
Thank you very much, sir. And I'll now pass on the proceedings to Dr. Tarun to take over the discussion forward.
Just few simple rules that anyone who wants to ask a question, just put up in the chat box. And after we have discussed few questions which we have prepared for the panelists, you will get your turn to ask those questions. So you just put your question in your chat box and then unmute yourself when we ask you to unmute yourself. So we will start with the webinar. The first question is of the OPD setups. So first question to Dr. Rana sir. Sir, what are the adequate OPD precautions to be taken if one is visiting the hospital for the patient and for the doctor both? Hello?
I think there is some problem with this connection. I'll connect with him. Meanwhile, you can proceed to second
Yeah,
question.
I can ask the next question. So what is the ideal OPD setup, Dr. Lal sir? Where should be the chair? Where should be the AC?
Well, we are much away from that in the reality. So I'll have to just follow the rules that have come up from the Ministry of Health and Family Welfare is to say that all the entrance areas where we are seeing the patients, like the OPDs and the lounges, are technically supposed to be the low risk areas. So you need to be keeping the spacing, need to wear your normal surgical mask, and keep the social distancing parameter, not allow more than one relative with one patient, so not more than 3 people in the room. The central AC is something that is of concern. Individual room ACs, which is the normal way in which the OPDs run, is pretty all right. But the central AC, we will maybe discuss it a bit later in the discussion. But normal low level protection is what is mandated at the OPD level or at the level in which the first encounter is taking place. We need to have alcohol, 70% alcohol based scrubs. So everyone should be able to follow the simple rules of hand hygiene, social distancing, keeping a mask, and making sure that we are using those basic precautions. A lot of those interesting discussions and videos and guidelines have been seen by all of us. So I think those are the ways, but I think more answers would be coming from maybe those who are actually doing the OPDs. Now, we at Maulana Azad and Lok Nayak Hospital have been turned into a total 100% COVID hospital. So we are rendered useless from the point of view of running an OPD for the next couple of months. But I think maybe faculty from Gangaram Hospital who are currently doing the OPDs there may be in a better way to address actually what they are doing in the ground.
Arvind sir, can you elaborate, sir?
Yeah, thank you very much and welcome to all the participants. So Tarun, regarding OPD, first of all, agreeing with everything that Pawan said, and my sincere thanks to Dr. Raghu for his very kind words, and to Delhi State Chapter, everybody for this organizing this webinar. Continuing with where Dr. Pawan left, I would say that as far as OPD is concerned, my efforts are to shift to tele mode as far as possible. So anything and everything which can be done in a tele mode, whether you use a simple video call, whether you use a WhatsApp call, or you use n number of softwares which are available today, So I'm running my entire OPD on a tele service where patients send the entire data to me on the WhatsApp. I see all that and then I communicate with them. At least 50% are those where actually you don't really need to have a physical contact examining them. So that reduces our exposure and their exposure, and only those who need real time to be seen in physical form, then we allot a time to them and follow the procedures as Dr. Pawan has told. So shifting to tele digital mode big time is the need of the hour. In summary, over to you.
So basically, I think that's a very important point which Dr. Arvind has said, that teleconsultation is going to be a large way in which we are going to be interacting with our patients, and we will need to get ready, get used to this norm. And very interestingly, the government of India has now come out with the guidelines for the teleconsultation. Even the charges, the rates at which we can charge, even those guidelines are now coming out, and we just need to get used to it. Only thing is the gray zone between what can be managed on a telemedicine and where we would like to actually palpate or see the patient is what is the critical situation. And I don't know what is the medico-legal fallout of not having seen a patient physically and the patient actually going sick and then coming back to you that you never said that you would like to see me. And look, it was, not just a ureteric colic, it was actually an appendicitis which perforated, and now I'm into an acute abdomen.
Tarun, can I add a word there?
Yes, sir. Yes, sir.
Yeah, agreeing 100% with what Pawan has said. Very, very relevant points. So I would say that teleconsultation should only be restricted to a point. I'll give you an example. Somebody is having hemoptysis. He sends me a CT scan which shows a bronchiectasis. It's a clear-cut bronchiectasis. I advise some antibiotics and some hemostatic agents, and I say, okay, let's talk again after 48 hours. Now, this kind of a situation can be managed on the telephone. But as Pawan said, if there is anything which needs to be seen, examined, please don't skip that and be in a hurry to prescribe treatment, because their error is there and the fault will be with you. So this reduces the load to some extent and gives you time to schedule the patient and call them as per schedule. Tarun.
Also, it is said that the flow of AC, if you are having, it should be from your behind to the patient rather than from the patient towards you. So all this aerosol would be coming towards you. So you can change your OPD setup.
Tarun, that's a very, very crucial point, and I keep repeating it to all my unit people. When we speak, the fomites which come out, the aerosol, it moves like a bullet. It moves in a straight line and it goes ahead. It does not take a U-turn. So when you talk to patients, you have to avoid direct face-to-face contact. So not only they should be sitting more than a meter away from you, but if they are looking some other way and there is a flow of air from you towards the patient and then away from the patient, their aerosol will be carried outside. Please don't use central ACs, and preferable to have only fans, pedestal. I have switched off the AC in my office. I'm using a pedestal fan with flow away from me towards outside, and if possible, open the window. There was an article this morning which said that none of us can totally avoid exposure. These are measures which will reduce the level of exposure, the volume of viral load which will be going. So as much air movement away from you as possible will reduce your exposure. Tarun.
Please mute yourself. And what about the exhaust fan, sir? Is it important, exhaust fan?
So Tarun, what I would say that the flow of air has to be away from you, and if there is a patient, it should be away, the direction has to be from you towards the patient and towards outside. For me, a window or a door, or if there are two doors and there is a possibility of cross ventilation, it's the best way, because it will reduce the aerosol load inside. There are a lot of examples where closed door people inside a room has led to a much higher incidence of infection than being in an open space. So have ventilation as far as possible. It will help you. Tarun.
Thank you, sir. So the next question is, what is the ideal protective gear equipment for OPD? Dr. Arvind, sir.
Well, OPD, if you are with the level of infection that we have in Delhi city today, I would presume everybody who's not tested to be positive. Symptomatic, asymptomatic, yes, we are checking everybody's temperature at the entrance, but every day we are hearing 30%, 40%, 50%, 60%, asymptomatic patient. So I would say, let's presume everyone walking into the OPD to be positive. Even those who have been tested, as we will discuss, the test is only 70% sensitive. So even a negative test actually can be false negative in up to 30%. So presume everybody to be positive. If you are going to examine the patient from very close quarters, like chest examination, abdominal examination, well, ideal would be to have a proper PPE and then examine that patient. Now, knowing fully well that in a large number of places, this not be possible. So my practical alternative for that is that you must have a cap. You must have an N95, and over that you can, if you want, you can have a 3-ply mask. But a face shield, to me, a face shield is a very important piece of protective equipment. Do have a proper gown and nitrile gloves, and do something to cover your neck also. So if you cover all the parts of your body from head to toe with something which can protect the virus from going into your body, it helps. Of course, first thing I do after coming to hospital is to change from my home clothes into OT scrubs, and I keep that scrub all the time. Yes, that's a nice picture you are showing. So you can see the person has changed into the scrubs. He has put on a N95 covered with 3-ply mask, in front of which he has put a very nice face shield. Now it's important that face shield covers from one tragus to the other and also goes below your chin. There are some half face kind of face shields that they do not really help. So you have a surgical clamp, and your mobile, which is the most dangerous piece of equipment you always carry, has to be covered with something which does not allow a virus to sit on that. So you can see there is a mobile waterproof case. So this is the kind of gear. And of course, I'll put a gown over it, and I'll also make sure that my neck is also covered by something. So from head to toe, you are covered by a layer. Inside you have these clothes. When you leave for home in the evening, you will remove all these gears. You will put on your clothes, go home, but not touch anything in your house, not hug your children, go straight to the bathroom, dispose of all those clothes and take bath with soap, and then you are ready to mingle with your family. Tarun.
Thank you, sir. The next question is to Dr. Parvinder Lal, sir. Few of our patients come as maybe an infected cyst, a minor OT procedures. So what is how do we select those patients? What is the minimum PP, and is there any role of testing in that?
So Tarun, I think we should put all our minor OT, elective procedures out of the scope at this time. We should be minimizing and restricting our surgery to only the very emergent or very semi-emergent cases. And all these minor procedures should not be done. However, if there is any need to do, we will have to follow all the precautions, as Dr. Arvind has just pointed out, with all the normal PPEs. And follow all the protocols as far as possible. Let us say there is an abscess, paronychia that needs a drainage. That's a common procedure, something like that. An infected sebaceous cyst, some ruptured abscess somewhere in the skin, furunculitis or anything like that. So all the usual precautions, you need to use the face shield over the patient, on the surgeon himself. There is no need really to get the patient tested. You see, this is an emergency situation. You see, we should understand this is not like an HIV, HBsAg or HCV situation where you need to test the patients before you do the surgery. This is a flu. We don't test ourselves for flu like influenza, H1N1 or whatever. We need to protect ourselves. We'll have to keep ourselves protected. And as very rightly said, we have to think as if patients are potentially positive and stay ourselves. Actually, the disease, this kind of a pandemic is going to stop when there is going to be a herd immunity, when it comes to 60 to 70% of the population getting infected. So there is no real point of getting every person tested unless that patient is undergoing a procedure which is likely to, who's likely to get a morbidity of a nature where the positive or negative is going to become an impact factor. Patient may become positive during the course. But for minor procedures, I would not insist for any testing. I would follow all the normal PPEs as has been shown in the picture and enumerated, follow all the sensible precautions and move on, and postpone all minor procedures which are not emergency to a later date.
Thank you, sir. My next question is to Dr. Manisha Agarwal, ma'am. Ma'am, what are the precautions you take while doing a pre-anesthetic checkup of the pre-operative patients?
Yeah, as Dr. Arvind earlier emphasized, the hand sanitization, social distancing, and adequate personal protective equipment should be in place. Your patient should be at a distance of at least 2 meters away from you, and he should be wearing a mask, proper mask, and the anesthetist himself or herself should be in proper gown, mask, preferably face shield also. And so for basic evaluation, I'll just try to tell you the specific points which are different from the usual PAC we do. You must ask the patient for any contact with any person who is known to be COVID positive, or history of travel to an area which is, the containment area. Then you must ask specific questions pertaining to the COVID disease per se, like a history of cough, breathlessness, fever, headache, GI symptoms like diarrhea. Many patients are manifesting for the first time with symptoms like diarrhea. So besides that, you must, very importantly, if the patient has some comorbidities like ischemic heart disease, hypertension, diabetes, what all medications the patient is taking, or if the patient is already COVID positive and he has been put on some drugs like HCQ, azithral, etc. So we must know, or any antiviral medications, because all these drugs may have interaction with our anesthetic drugs. So we must know and may need to do certain specific investigations. For example, an 12-lead ECG. For example, patients on HCQ, it causes an increase in the QT interval, and patient is prone to arrhythmias intraoperatively or perioperatively. So, and all the comorbidities must be optimized, because as Dr. Parvinder also mentioned, if these patients are subjected to some surgical procedure under anesthesia, they do have a very high risk of developing post-operative complications, including ICU admissions and post-ventilatory support. So all this thing should be taken into account. As far as possible, only emergency surgeries should be undertaken during this period. Elective surgeries should be deferred, and investigations like hemogram, liver function test, kidney function test, serum electrolytes, 12-lead ECG and X-ray chest, very important, if possible, should be done. And along with this, a very important component of pre-anesthetic checkup is consent, a written informed consent from the patient, explaining him the due risk involved in the surgery and the anesthesia that has to be undertaken for the same, and the possibility of all post-op complications like even post-op ventilatory support.
Thank you, ma'am. Now our mainly OPD section is finished. Now we will go for testing. So I will request Dr. Vatal sir, the question, sir, what are the types of COVID tests which are available, and what are the advantages and disadvantages of each? Dr. Chan Vatal sir. Sir, unmute yourself, sir.
Do that.
Yes, sir.
Yeah, am I audible now?
Yes, sir. Yes, sir.
Thank you, Tarun, for getting me here. This is not a very big question actually, and most of you know that we do not have a lot many tests as on today, as far as COVID-19 SARS-CoV-2 is concerned. The primary test, which we are still talking about as a gold standard, which Dr. Arvind said that has false negatives, is the RT-PCR. Well, that is the primary weapon as on today that we are trying to pick up the cases. That is the RT-PCR. Having said that, then there is another not very famous test as on today, that is the serological assays. And we all have seen that serological assays have not really done well as far as the ICMR seroprevalence studies are concerned, because the lack of probably some very good case also. But we have a very limited experience I can share when you need to know that. So our primary tests are RT-PCR, and then is the serological assays. So these are the primary two tests. In fact, one test only. So back to Tarun.
Dr. Ujjwal, can you talk of importance of serology test and what is its clinical relevance? Can we as doctors get it done, and what is its relevance?
See, as Dr. Chand Vatal has said, that there is a very limited role of serological tests. At present, RT-PCR is the only test that should be done for diagnosis of acute illness. At best, the serological test can be used to know whether the person has ever had an infection or not. But that is also, at present, in current pandemic, it has a very limited value. Reason is that at present we all know that the prevalence of disease is very low. Prevalence of antibodies in the population, general population, is going to be very low, maybe less than 5% of any population. So whenever the prevalence is very low, the predictive value of the antibody test goes down. So if I just trying to explain to you, if the sensitivity of a test is maybe around 90%, specificity is 95%, the serological test positive predictive value would be around 49 or 50%. So it cannot be used as a diagnostic test, number one. Number two, if at all we want to use it, maybe at present what we are doing, since we are seeing a lot of patients, at times RT-PCR comes out to be negative and we are suspecting strongly that this patient has COVID infection. In those situations, maybe doing antibody tests, if that comes out to be positive, may help us in making an indirect diagnosis. That is what I feel is the current value of the serological test.
Dr. Ujjwal, if we get our test done and we have IgG antibodies for COVID, maybe out of 120 doctors, so are we more safe to do the practice, or we are equally susceptible in long term?
See, at present, the predictive value and the diagnostic value of these tests is very low. As you have seen that previously, there have been a lot of news that these tests have been either falsely positive, falsely negative. So doing this test doesn't save us, because we do not know whether we have had an infection or it's a falsely positive, serological positive. So I don't think that we should be relying at all on this serological test at present, even for ourselves.
Okay, thank you. Dr. Vatal sir, what is the importance of false negativity in this RT-PCR?
No, before that, I will just allude to the Parikh's question, the Ujjwal's question that you had done. That is a zero assay. You wanted to say that you get immune when you develop antibodies, probably. Well, it's a imperfect science as on today. Please understand that. We are still not very clear these are only neutralizing antibodies. And are these neutralizing antibodies really giving you immunity or not? It's still unresolved question. So you cannot actually lower your guard. So having said that, this is what I wanted to share with you. And what was your next question now?
False negative, sir.
False negatives, yes. False negatives are really is a possibility. And there are various situations where it can get false negative. If the sample is not properly taken, if there is not a good nasopharyngeal swab that you put the stick inside and don't push it enough inside till it reaches the resistance, rotate it well, and then try and collect that. So it's an incompletely collected sample. That is the one way of it getting negative. Another way is that it has not reached the threshold of detection. So it may be at a very early stage of incubation period when you will again get it negative, or he has passed the stage where of viremia, again it will come negative. So you have a very critical period when it going to be positive. That is when he gets symptomatic. Probably you would look at him, and then maybe 7 days after that you may expect that it has become it will should come positive. So these are the kind of negatives that you usually see. And then obviously if the test is not properly done or the sample has inhibitors, there are samples in the PCR test, if they have inherent inhibitors, you cannot run them on RT-PCR. And I have not seen many people actually looking for that. And now these reactions are inbuilt to tell you that the ICs or the internal control is not in place, so there can be inhibitors. So you need to have an alternate platform to test them. So these are some of the situations where the RT-PCR will get negative.
Thank you, sir. Dr. Ujjwal?
I just wanted to add that the timing of doing tests is also very important. If you do it very early, maybe a person has had an infection and it is not beyond a certain point where the disease has happened, then you are very likely to get a negative test. So timing of doing RT-PCR is also very important. It should be beyond 5 days of infection. That is the minimum that we should be doing. Doing early is not going to help. That is why even in contacts, doing it early is not helpful. It should be done 5 to 7 days after the person has had a contact with the infected person. Secondly, if we are doing a test, maybe after a person has had a symptom, maybe at that time the screening goes away. It is no longer a screening, we are doing a diagnostic test. Now, if a sample is taken after 7 to 10 days of an infection, then the sensitivity starts to go down. And after 14 days, it left around 50% sensitivity only. Because when the infection goes into the lungs become more sensitive and specific for the infection rather than the throat. So timing of doing the test is also very, very important. That should be taken. The ideal time is between 7 to 10 days when the test should be done.
Thank you. Dr. Ujjwal, pre-operative COVID testing, is it allowed, and do you recommend, and what type of testing should be done?
I think a little bit has been told by Dr. Lal that a blanket doing test is at present not the way forward, because this is an infection which is going to be with us. Doing a test, if the test comes out to be negative, is no surety that the person doesn't have an infection. So one thing should be very, very clear, that taking universal precautions, all the precautions is very, very necessary, even in negative patients. Now, if we are planning to do a surgery, especially the laparoscopic surgeries in which they say that there's a lot of aerosols in vision, then probably it is wise to do a test. The reason to which is not from the patient point of view, but from the healthcare workers point of view, because as in HIV, if we do a test, then we know if there is a breach in taking all the precautions, then we know that what all prophylaxis or what all actions we have to take. Probably I personally feel that if we are doing a test in probably a prolonged surgery is not a wrong thing.
Dr. Bartel sir, you will like to add something?
Tarun?
Yeah,
yes,
Tarun, can I just be off for 5 minutes? I just have to answer questions on another webinar. I'll be back in 5 minutes.
Yes, sir. Yes, sir. Yes.
Thank you. Very kind of you.
Bartel sir?
I fully agree with Ujjwal that yes, you need to learn to live with it, and then take the precautions, which is the basic of preventing yourself from getting the disease, because any of these patients can turn out to be positive tomorrow.
From the point of view of nursing homes, because if we are doing a patient in a nursing home, it is very difficult. If patient comes post-operatively positive, how will they manage? So at least I think most of the nursing home people are doing their test before doing surgery, and I feel that is much better to do it rather than not do the test, because if cost is not an issue at this point of time, if possible, better to get the test done rather than not get the test done.
No, you may try to err on that side. That's all
Yeah.
right. We're having some
It's better to
publications.
do it rather than not do it.
Yeah, where the people are saying that the mortality and morbidity in COVID patients is probably higher. But I do not know whether those are peer-reviewed articles as on today, because all these articles are coming at a breakneck speed. You need to know the veracity of them. So are you ready to believe that 30% of such cases will have higher mortality and morbidity? So that is also to be seen. And if you want to test them, then the information, even if it is negative, then it may give you a false sense of security. You have to really think as to at what stage of the disease the patient is. The test may not be the only answer. So they have to take the precautions. There is no doubt about that.
Dr. Ujjwal?
Yeah, I just wanted to add to what Dr. Vatal has said, that if you do a test one day prior to doing a surgery, it can falsely come out to be negative. And if the person has a longer stay in the hospital, maybe 6 days, 7 days, or 10 days, he may turn out to be positive. So what the bottom line is that we have to take all possible precautions in every patient, number one. Number two, doing the testing would at present be more, I would say, individual question, and if a person wants to do it, it can do it. But if we look at a larger perspective or a country point of view, doing this test individually in each and every patient would not be right. If we extrapolate this thing, then there are lots of procedures, non-invasive procedures, invasive procedures being done, and you can imagine the number of tests the person is going to undergo. But at the same time, I want to add one more thing. There have been instances where a person who has been going to dialysis has been negative initially, turns out to be positive, and there has been a lot of contact cases in those cases. So I do not have a perfect answer to this, but would say that it should be a combined decision between a patient and a doctor. If the patient says yes, you can go ahead and do it, maybe do it.
When do you retest if patient is negative and you are suspecting that patient might be positive? Once it becomes negative.
As I said that initially the patient can be negative. Maybe you have done a test in a very early stage, so he can be negative. So maybe you can repeat the test maybe after 2 or 3 or 5 days if you are strongly suspecting that this patient can have COVID infection. If you are not suspecting, just for the sake of surgery, I do not say that we should be doing a repeat test in those cases who have turned out to be negative, unless they develop a symptom.
Dr. Vatal sir, is becoming negative important? Like patient has become positive and now has become normal, is having no fever. So is testing to make that patient go out to work, does he has to be negative? Repeat testing is required? Dr. Vatal sir?
You see, there is a difference between two people who are having COVID positive, and now you want to test them whether they are negative or positive. If you look at the guidelines that has come from the government of India and the ICMR, they are now left it open that don't test and let them go. And 17 days isolation or quarantine, whatever you call it, they tell, okay, fine, for 17 days they are confined, and then don't test them, let them go if they are asymptomatic and have settled. But the issue is of healthcare worker. A healthcare worker who has to come back to the place of work where he is going to come in contact with patients as it is. So healthcare worker scenario, my personal opinion is that they should be tested so that they are not shedders, so that you know that they are not shedders and they are not giving it to the patients. So that is my way of looking at it when you say that do not test. But this kind of a sect of people, they should be tested. And we should know that their RNA status.
Thank you, sir. Thank you. Dr. Ujjwal, you want to add?
Yeah, I just wanted to add a little bit to what Dr. Vatal has said, because I've been seeing these kind of patients, and the whole week I have been taking round of our COVID hospital. So there are 2-3 kinds of scenarios in which the patient would require to get a repeat test. These are both medically important and socially important. That some of the patients are living in a rented house, and their tenants would say that we would like to have, obviously they are living with others also, they would like to have a negative report before they allow them to inside. Secondly, the healthcare workers have rightly said that because they are going to come back to work and they are going to be in contact with people, and we do not want them to become a disease spreader. Because as we have seen that Dr. Vartal has said that you have a 10 days of disease-free period, maybe 17 days of quarantine. That is not fixed, because we have done tests after 10 days, 12 days, 14 days, patients, they come out to be positive. Whether they are truly positive or they are falsely positive, we do not know. But we have seen patients, we have sent, they are asymptomatic. They have become asymptomatic for last 7 days, and we are sending the sample, and for 3 times we have sent the sample, still coming out to be positive. And that person is a healthcare worker. Can we send them? Can we send these patients back to their work or back to their home? Is a question. So at present it's a very evolving science or evolving knowledge. So we do not know what is the perfect answer to this. Whether we need a negative result actually for everybody, or we do not need a negative result for everybody. Time is going to tell about all.
Achha, Dr. Ujjwal, next question. What is the role of HRCT/NCCT/CCT chest for diagnosis of COVID? Mainly diagnosis, not prognosis. And chest X-ray also.
See, there is, I would not say there is any diagnostic value to this. It is more of a prognostic value or disease progression we need to know. That is the reason why we want to get it done. Those patients who are asymptomatic rarely would have lung lesions on an X-ray, to be very frank. So getting an X-ray done just to diagnose a patient of COVID is not probably what is required. But yes, there are certain things that come on an X-ray, then we can say that this person has moved from a mild to moderate to severe category. That depends on the amount of lung involvement that we see on an X-ray or a CT scan. And there are certain typical signs that GGOs, patchy areas of GGOs that we see, ground glass opacity that we see, especially in the peripheral area, which is said to be very specific to COVID. But that is not diagnostic, number one. Number two, that is not the only radiological sign that comes. There can be other things also which are not very specific to COVID. So I would not say it has a diagnostic value. This has more of a clinical value and a prognostic value in patients who have a COVID infection.
Like we have to go a CT scan abdomen for maybe a perforation peritonitis. So it is always a good thing to do a chest also in this scenario along with CT abdomen, so that we can just have a in this pandemic. That is what recommendations in our surgical society are, and we just have to operate it.
Tarun, at present people are trying to be absolutely safe, thinking that they will get away without getting an infection. So I don't think that is right. Again, exposing a patient for another CT scan is not the right thing. If a person, if you have a person who has symptoms, only those patients should undergo these kind of investigations. These are not screening investigations, I would say, at present for this infection. We can't use it as a screening investigation.
Dr. Arvind sir, will you like to talk about this CT chest as a diagnostic value if we are doing a perforation peritonitis?
See, Tarun, this had come basically from China, and this was in the time when their tests were still developing. And I cannot share the source, but I'm also informed that there are certain states where the testing is extremely low, and some of the surgeons are resorting to doing CT as a screening investigation. However, I agree with what Dr. Ujjwal has said, that as of today, I don't think I would be recommending it as a routine pre-operative test. In fact, I would summarize this whole thing by using one sentence. If we have to choose between universal testing versus universal precautions, under the circumstances where we are today, Tarun, universal precaution is the need of the hour. You know, RT-PCR availability is an issue, 70% sensitivity. Dr. Vartal has beautifully explained reasons for the false negativity. So even though you do it, in fact, I would shudder to think of a patient who's actually positive and turns out false negative, and I lower my guard and take less precautions and end up infecting myself. So I would summarize, universal precautions is the answer till the time we find 100% sensitive and easy method of diagnosing this disease. Of course, till then, RT-PCR will continue to be our gold standard.
Thank you, sir. So now we will go to this ROT questions. And our first question is to Dr. Lal. There is a concept of emergency life-threatening emergency surgery, semi-emergency surgery, and elective surgery. Can you elaborate on that, sir?
On the testing, can I ask one question?
Yes, sir. Yes, sir.
What is the role of the new test, the TrueNet? Because you have experts here. Can they enlighten surgeons on the value of TrueNet and that it's more definite, less false negativity? So Dr. Ujjwal or Dr. Vatil can explain to us.
Dr. Vatil, sir?
Yeah, thanks for bringing it here. It is primarily, not a test which will actually put other tests to shame. It is only a test that gives you the results much quicker, and it can be taken to the peripheral centers because it's a standalone machine which can actually do the test. But unfortunately, it is a more cumbersome test which has come up, and it has multiple tubes that are being to be used. And we were discussing actually in our own group that they have also replaced their VTMs with a vacutainer vial. And the vacutainer vial has to be actually flick opened. It cannot be opened very quietly or with a screw tube, which was earlier, but now they have put in the vacutainer vial, which is likely to produce an aerosol and create a nuisance with the healthcare worker. But it is just like any other assay which we are talking about, but it gives the values very quickly. As we have by CIFID, we have the gene expert or the biofire that we have from Biomerio. These are the tests that complete within 45 minutes. That is what they usually are actually into. The TrueNet testing laboratories have to fall back on some of the confirmatories because they have to test a confirmatory test also. And another gene has to be tested, that's RDRP. And they fall back on those laboratories or the centers where they are RDRP also being done. So then it completes the test, and at the same time they can release the reports very quickly for the results. That's the only difference. The sensitivity or specificity is not any way different than the other rapid tests that are available, like CIFID's gene expert or the biofire or Biomerio.
But is the false negativity not there? That is the key. That if a report comes negative, we can presume it that this is 100% negative report.
So as I said earlier, when you're talking of the 100% scenarios in science, we all know it doesn't exist. That's number one. Number two is if the sample is improperly collected, you will never know whether it was negative because of what. So or if you are not having proper ICs and there are inhibitors, as I said earlier, you will not really differentiate unless the IC is really looked into. There are some tests where the ICs are not there. And if there is an incomplete collection of sample also, where you are not putting in the adequate number of cells, which have to be lysed and the virus to be taken out, then again, the test can get negative. So for the negatives, we do know some kind of a ballpoint figure. You can decrease the false negatives to the good extent if you take care of these basic few of the make it false negativity you can decrease by another 10 to 15%, up to 90% you can reach in RT-PCRs. And that too, in those cases, we are not talking of asymptomatic ones. I'm talking of the symptomatic ones where the false negatives can be considerably reduced by looking into the other methodological issues.
Okay.
Dr. Ujjwal, you want to say something?
Yeah, I just wanted to add, Dr. Vatil has rightly said that it is not 100%ly, I would say, the correct thing to do. But probably this has been extrapolated from tuberculosis. In tuberculosis, they say that by doing TrueNet, the number of bacteria that are required is very less to pick up those things. But this increases the sensitivity by a little bit, but it doesn't replace the value of other tests. So this I would say would just help us in decreasing the time that is required to get the test done, rather than increasing too much of sensitivity and specificity of the test.
Thank you, Dr. Ujjwal. Dr. Lal, sir, can you start with the...
Yeah, so I think all of us surgeons are aware that what is emergency surgery. Just to say that something like acute appendicitis or irreducible strangulated hernia, acute abdomen, anything like that with, pus peritonitis is going to fall into clearly emergency surgery, and patient should not be denied surgery at this time. And this is going on. And I'm happy to say all the surgeons, both in the government and in the private sector, are actually delivering care to both COVID positive and COVID negative patients. Although there have been challenges in this care, because of so much of scare around, both on the patient side reaching the hospitals, and the hospitals having to deal with the enormous pressures of segregating the two types of patients. But in any case, this surgery cannot be denied. There is other side is the elective surgery, which is planned surgery, which also is very clear as of now that should not be done. It is not safe to be done, considering the risks that it is posing, so long as we feel that the elective surgery will not be putting the patient's life into threat. Now, in between there will be some gray zones. For example, if there is a case of acute cholecystitis. Now, all of us know in the government sector here, we do not operate acute cholecystitis. We still manage it in the old classical book way, that you put the patient on IV antibiotics, and 99% of the patients actually don't require emergency cholecystectomy, and they are treated by interval cholecystectomy, which is what I would like to advise all the surgeons who normally deal with acute cholecystitis by going in immediately and doing a laparoscopic cholecystectomy in the acute inflammatory phase, which is what is described in the initial 24, 48 up to 72 hours. Now it has been extended to 96 hours. That kind of surgery can be easily postponed by giving antibiotics, to be deferred. Why we need to do something unnecessarily? Risk for the surgeon and risk for the patient is both there, especially where the general anesthesia is involved, aerosol generating procedures are involved. Both GA as well as laparoscopy involve a lot of aerosol generation, and we'll deal with it in the later part possibly. And this is one gray zone, I think, which is acute case, which can be managed. And on the other hand is elective cases in a semi emergency type, like for example a malignancy which is causing obstruction and needs to be operated or cannot be deferred. Those will be possibly two types. Ones which need to be operated, where you need to go in the malignancies or cancer surgeries because it is life threatening, like impending perforation, or an obstructed case which cannot be managed by other means, or if there is a possible to defer the main surgery by way of using neoadjuvant chemotherapy, radiotherapy, then possibly surgical procedures could be deferred in those cases. So I think these are the only two gray areas. Otherwise, clearly emergency on one side, clearly elective on the other side. I think this is all well settled, but we should try and avoid wherever possible at this time, until the plateau is reached and we are on a downward trend and we are kind of seeing recovery from the patients. We should be able to hold on to the elective surgery as of now.
Dr. Lal, again to you, which patients to be avoided for surgery? What are the patients specifically you feel that they should not be operated at all, if possible?
So I think I've already enumerated. In that, I would say, the elderly people who are at risk, patients who will be having comorbidities, all these patients will be patients, and all the patients with standard elective surgeries. These are the people who should be, who you should not be dealing with. I don't think there is much of a choice between the criteria within the patient group. I would say that the criteria should be emergency, life-threatening, or something that can be deferred to a later time.
Thank you, sir. Dr. Raman Goel, sir.
Tarun, can I just add a line to that?
Yes, sir. Yes, sir.
Agreeing 100% with what Pawan has stated, I would just mention one sentence that one of the risks is if the patient is COVID positive and you operate, you are actually inviting a very high post-op mortality. I read a report from China which actually was reporting as much as 20% mortality in the post-op. It's something like, you know, a patient who's in a developing phase of viral hepatitis, and you subject him to anesthesia and he goes into fulminant hepatic failure. So if you're by chance your patient is COVID positive, the only time you would take him for surgery is if it's a life-threatening emergency. If you don't operate, he will die anyway. Other than that, it should be avoided as far as possible. Tarun.
Thank you, sir.
I just
Dr.
need to
Raman
come
Goel,
in.
sir?
Can I come in for a minute?
Yes, sir. Yes, sir.
Yeah, I would like to ask Dr. Manisha here that if there is a emergency surgery in a possible COVID positive patient, what are the precautions that their surgical team is doing so that all of us are all of us are surgeons, and some of them will be organizing their operation theaters, you know, to deal with such a case for the first time. What are the guidelines which you would like to give? Some other equipment which we need to add in our armamentarium, like a cage or that plastic thing or cover, other than thing, please give us a little bit of a idea so that everyone is able to know how to deal with it.
So as we have been talking, because of the high transmissibility of this disease, this virus, the COVID OT has its unique requirements from the anesthesia side as well as from the surgical side. So you must have a dedicated COVID OT in the COVID block of your hospital. You should have large billboards which display clearly written in the local language that it's a COVID OT. Then you must have, the dedicated donning and doffing areas. And before that, it is better to have 2 theaters, COVID OTs, one which is dedicated to the obstetrical emergencies like cesarean sections, and other OT is reserved from other surgeries like general surgeries, orthopedic or trauma, etc. for all age groups. Then you must have changing rooms which should be well equipped with toilets and shower facilities. Then dedicated donning and doffing room, which is very, very important. The donning room should have sterile PPE kits, then facilities for hand sanitization. Then similarly, the doffing area should have hand sanitization and bins for proper disposal of your used PPE kits. Thereafter, then if possible, you must have facilities to open your doors with elbows or your feet without touching the handles, etc. Then all the necessary equipment should only be placed inside the OT. Unnecessary extra equipment, including the linen and the drapes, should be removed out of the theater. The surgeon should be entering the OT, unlike the usual way where the surgeon is already inside the OT when we are anesthetizing the patient. The surgeon should enter the theater only when the patient is anesthetized and absolutely ready for the surgical procedure. Even as anesthetists, we prepare our drugs, etc. outside the OT, and only the tray loaded with the drugs is carried inside the OT. Then there should be a separate entry and exit, and there should be no intermingling of the personnel between the green zone and the red zone. Then all the equipment inside, including our anesthesia machine, monitors, suctions, your whatever cautery, etc. needed, should be ideally be covered with plastic sheets, which should be changed after every case. And then very important, communication between the OT personnel. Instead of speaking, it's better to use the sign language, and everybody, including the anesthesiologist, should not be writing down on papers. The hard paper case sheets should be lying outside the OT, and minimal personnel should be allowed to work inside the theater. Maybe 2 surgeons, nursing staff, 2 anesthesiologists, and a technical staff. And a runner should always be placed outside the OT so that anything urgently is required, is brought to the OT. And then as against the usual process, when the surgery is over, the patient is allowed to recover completely inside the OT. We do not shift the patient to a separate post-op recovery room. And when the patient has recovered, he is directly, shifted to the isolation ward or HTU. Wherever according to his surgery or the pre-op condition. and how he has behaved intraoperatively.
Thank you very much. I think there were so many details that you covered there. Small points which are very important, especially for those who are running their own, nursing homes or operation theaters or working. I think that will be a very good, it covers so many things. Thank you very much. Dr. Tarun, please continue.
Dr. Raman Goel, sir?
Yeah.
What is the, when to start elective surgery? That is the biggest question which we all private practitioners of Delhi, Bombay, and everywhere are, is it safe?
So, the entire discussion about emergencies and elective surgeries and semi-emergencies is based on a perception. And we all know that the numbers are increasing. We are one of those few countries where the numbers are increasing, and we have not, as is widely discussed in TVs, we have not gone above the curve. So I think starting elective surgery at this time should not be even a discussion point. What is more important at this time is, and IAGS came out with a guideline about a week back on resumption of laparoscopic surgery, resumption of surgical practice, is that for how long can we defer patients who were semi-urgent, like somebody has an acute cholecystitis, and we said we are deferring it for later, but this virus is not going to go away. If the numbers are going to go and keep on increasing for next 3 months or 6 months, do we make an acute cholecystitis patient wait till they have a pancreatitis attack? Or if somebody has an acute appendicitis, do we want them to wait till they have a... So I think at the moment, Tarun, the focus should be on such semi-urgent deferred cases and whether they can be taken with adequate precautions. Now, it depends on the city that you are. Like I'm in Mumbai, 80% of the private hospital beds are with the government for COVID patients. So practically there are no beds for private practitioners, So we can't do a, let's say, even a elective cholecystectomy or a deferred cholecystectomy. Those 20% beds are basically for dialysis, for deliveries, cesareans, and things like that. But if you are in a city where the numbers are very less or they are just in double digits or single digit, maybe you can do it. Because in a city like Mumbai, KEM hospital statistics was told to me in confidence that 1 in 4 patients in a non-COVID situation is turning out to be COVID positive after surgery. And I was told almost similar figure in Delhi, about 20%, 1 in 5 patients are turning out. So when the patient load in a city is so high, thinking of elective is out of question. And I think that's what we owe to our patients. Let's not get restless that we have not been operating for last 2.5 months and I can do it safely, or some kind of jugaad is available and we can do it, because this can kill a patient. Or if the patient gets infected, as Dr. Arvind rightly pointed out, has a stormy course after surgery, we will never be able to forgive ourselves. So I think elective surgery is too far, and almost every city is going to follow the same route that Mumbai and Delhi are facing today. So now we are seeing it in Chennai, and it will happen in other cities. Numbers are increasing, and even smaller cities will get involved. So one of the challenges that we are facing as a surgeon and in an association, how long we tell surgeons not to operate or defer the surgeries which came as an emergency or semi-emergency. Do they need to wait for 1 year, or we need to wait for 6 months? When will we be able to operate these patients? Elective obviously are no at the moment in India.
Thank you, sir. One more question to you, a specific question. Can we do conservative management of acute appendicitis when the curve is rising?
I think ideally it should be done. But since we are in a situation in India where lockdown is being opened as the numbers are increasing, we need to take that into perspective. And that's exactly what I said earlier. If I'm in a city like, let's say, any city, let's say Meerut or any city near Delhi, which has patient load in the city in double digits or single digit, probably it's better to do an acute appendicitis and get over with it rather than when it becomes in 4 digits 2 months down the line. That's my personal opinion, because the association guidelines speak other way, because we need to go with with the government guidelines. But what I see in Mumbai is 2 months back, we were in just in double digits, or let's say in hundreds. And now we are talking in 20,000, 25,000 cases in Mumbai alone. So that patient, what we deferred 3 months back, is still waiting. And as the numbers are increasing, beds are not available, surgeons are not available, things are going to get worse. So I think this is a moral dilemma. It's a legal situation for government. So government is trying to keep everything safe. But as far as the surgeon is concerned, and patients trust in us. So I was talking to a rural surgeon, and he said, Raman, for how long these people trust me? And when I say I cannot operate you and the person dies 15 days later, they lose trust in me. They don't know why I said no. So I think it's something like a gray zone, as Dr. Pavninda was rightly saying, and we need to take a call individually.
Thank you, sir.
Can I make a point here?
Yeah, Vivek, good.
I think this is a very important thing, and what I will just tell my experience of last 1 week. I have done 2 appendicular perforation peritonitis and 3 gallbladder perforations in just 1 week. And the problem is patients are not coming by themselves if they are not sick enough to come to hospital. And it is, especially in private sector, patients are themselves choosing only in a very advanced stage of disease. So I think calling gallbladders and appendices an elective procedure, we have done as a department around 10 cases in last 2 weeks. We have not seen any of those patients having a simple gallbladder disease, which we used to do very commonly earlier. So let us not, and obviously these patients have to stay longer now. Some patient will develop a biliary fistula after GB perforation if you do it. Some patients will end up with open cholecystectomy. Some patient will end up with laparotomies rather than laparoscopy. Some patients one patient actually presented with a necrotizing fasciitis of retroperitoneum secondary to appendicitis because he was taking conservative treatment, and then he was a diabetic, and the retrocecal appendix led to a retroperitoneal fasciitis, and now he's being treated with high-end antibiotics. So it is, let us think from a patient perspective. I agree with Dr. Goel. I think people have a lot of trust in us, and we need to make a call. Not just thinking that we should defer all these cases.
Yeah, Tarun, there are 2 issues in this. One is, as we are discussing, this is one thing, but ultimately patients will need to be taken care, and we need to take a call at some stage. We have collected actually data from about 17 centers across country of more than 1,000 surgeries done in lockdown period. And you won't believe, unlike the Chinese data, none of these patients had post-operative COVID. And these are busy centers of Delhi, Mumbai, Chennai, and various places, Kolkata and Guwahati. And one out of 1,000 patients post-operatively, either the status was unknown, but they were asymptomatic for COVID, or they did not have COVID. And we are preparing, analyzing the data, we'll publish it very soon. So that will show that there is a window of opportunity before the number goes overhead, before the real surge comes in cities. So I think it's a very delicate situation. And second thing is, the members of our association ask, you are not giving us definite guidelines, but the question is, where in life you have black and white? These are gray zones, and we need to work in those gray zones. We are also working in the same gray zones. And I think every surgeon has to accept that as a part of our profession.
I think Dr. Rana sir is there. Dr. Lal wanted to talk to sir.
Good evening, Dr. Rana. Welcome back. You were in a meeting. We would look forward to having you and your advice upon the way the hospitals are currently managing the surgical procedures at this time.
Dr. Rana sir, can you unmute yourself, sir? I think.
So meanwhile, Tarun, you can move on with the discussion. We'll just get him into the.
I think, he said he's there. He's just connecting.
Tarun, unmute yourself.
Dr. Lal sir,
Yeah.
what is your algorithm for ventral and inguinal hernias for a painful inguinal or a ventral hernia and lap and open both? What do you feel what should be done for these patients?
I mean, in the COVID era or
COVID era.
sit tight on them and see them a bit later. I would say. I mean, unless they're obstructed or they are, symptomatic, I would see them a bit later.
Symptomatic. I'm talking of symptomatic only, sir.
Yeah. So if there are symptomatic, we'll have to see if they are irreducible or getting strangulated. We will have to go in. I think the ventral hernias can be both open and laparoscopic. I don't think the current guidelines that have come in from our own 3 associations. We am very happy to say that 3 laparoscopic associations, IAGAS, which is led by Dr. Raman Goel, CELSI and the AMASI, all 3 have come up with a combined guidelines which have now been published in our journal as well, which are of the opinion that with due precautions, laparoscopic surgery is actually possible to do. There are certain precautions that we need to do in terms of the gas release and use of certain filters. So either way, whatever.
So you are Dr. Rana sir, you are on.
और भी फीडबैक देना है उसको और रह गया तो चला गया बोले ये भाई
Dr. Lal sir, I think Dr. Rana sir has not able to do it. You can continue, sir.
Yeah, so basically there is a choice between open and laparoscopic and choice between regional and general anesthesia depending upon the location of the irreducible hernia in the abdomen. And I think here I would bring in Dr. Manisha again to say whether she feels that is there an advantage of doing procedures which we can do under regional anesthesia versus the ones which we would like to do under general anesthesia.
Yes, the choice of anesthetic basically depends on the suitability of the patient, the type of surgical procedure, and the risk of viral transmission to the managing team. Regional anesthesia, as we all know, is not associated with any aerosol generating procedures as compared to general anesthesia. No intubation, extubation, suctioning is involved. Plus, so the risk of viral transmission is much, much less. And secondly, the regional anesthesia also does not affect your respiratory functions and dynamics to a large extent as compared to your general anesthesia, which is again a very important aspect in COVID patients which may have already lungs affected, so respiratory compromises there. Besides that, regional anesthesia has its own inherent advantages as against general anesthesia, providing very good analgesia, low consumption of opioids, low post-operative pulmonary complications. So in such patients, regional anesthesia is a very good choice, very good option. However, there are certain important points which should be taken into consideration. Like, for example, we must rule out the contraindications of regional anesthesia in these patients, like presence of local infections, coagulation problems, and very important, the hemodynamic stability. If for some reason your patient is hemodynamically unstable, then we would not like to administer regional anesthesia, especially central neuroaxial blocks like spinal and epidural anesthesia. However, having said that, if your patient is hemodynamically unstable because of a correctable cause, he's just simply dehydrated when he presents for a surgery, you have enough time, then you can resuscitate, hydrate him, and go on with your regional anesthetic. taking all other precautions. You have to, balance your risk and the benefits. But yes, regional anesthesia remains a very good choice of anesthesia in these patients.
Thank you, ma'am.
And especially, I would like to share that for obstetrics, we have done over 25 cesarean sections in COVID patients in our hospital, and they have been absolutely fine. We have had no complications. So we conducted most of our cesareans under combined spinal as well as epidural, because the surgeons, the surgical team, after wearing the PPE kits, were taking a bit longer than the usual cesareans done. So we were very happy with our anesthetic technique of spinal and epidural. Thankfully, we have no complications.
Thank you, ma'am. Dr. Raman Goel, sir, next question is to you.
Dr. Tarun?
Yes, sir.
Dr. Tarun, Dr. Rana is on the line. If you want to ask
sir.
the question, I can see him there.
Rana, sir?
So can you...
Dr. Rana, sir?
Bolo.
Good evening, sir. We are lucky
evening,
to hear your voice. Everyone is laughing now.
I am trying to handle COVID situation in the hospital. So.
Yes, sir. Yes, sir. Sir, 2-3 क्वेश्चन आपसे पूछने हैं. एक तो डॉक्टर लाल पूछना चाहते हैं. डॉक्टर लाल पूछिए सर.
नमस्कार सर, कैसे हैं आप?
क्या हाल है तेरे?
बिल्कुल ठीक है सर. आप ये बताएं सर सबके लिए कि इस टाइम पे हॉस्पिटल मैनेजमेंट को अलग से क्या चीजें करनी है ताकि वो अपने स्टाफ को सेफ रख सकें और ऑपरेशन थिएटर्स को और ओपीडीज को चला सकें ऐसे टाइम पे जब लॉकडाउन खुल रहा है या खुलने वाला है.
तो यही जब all precautions which everybody is supposed to take, that respiratory hygiene which have been told very nicely, and personal hygiene and maintaining distance. With these three precautions, we have to work, whether it's a hospital or workplace, we have to ultimately work and learn to live with corona. I don't think either we decide that we close down the establishment for the next 6 months or 8 months, or else start living with it, And otherwise, these institutions are going to face closure.
I think
we were having hot discussions for the last 4 hours, and I was very I could not attend your. I was listening to you people, but at the same time conducting meeting, So
sir, in
difficult times, it is important. Arvind told that encourage virtual consultation. There is no doubt about that. But everything cannot be sorted out by virtual consultation. After all, if somebody requires surgery and all those things, whatever can be done by virtual consultation, that should be done once for all now, so that load on the hospital is less otherwise also. But at the same time, we have to take a very pragmatic approach to come to the work and start, Otherwise, anyway, either we keep the lockdown, total lockdown, and for next 6 months, 8 months, which is not a pragmatic approach, or maybe extremely difficult. At some one time or other, lockdown had to be opened right now. And eventually, I think that is my thought, that we have to start working, and that is all what I'm doing at this stage also. You tell me, what are you thinking? You are the young people, what are you thinking?
No, sir, I think all of us are very keen to start working, but we are kind of in a situation where there are guidelines which are limiting us, hospitals which are not either available to us or are,
No, listen. Actually, in fact, the way we are saying now, convert hotels also to hospital, which is, I think, such an impractical and non-pragmatic approach. How can you?
Oh, he has to be unmuted.
A hotel into a hospital, and we have to limit the admission of COVID positive patients. COVID positive patients, only those patients should be admitted in the hospital. Those who have got some earliest symptom of respiratory insufficiency or respiratory failure or need for oxygen. Otherwise, we are just admitting them and keeping away them from family, also giving them food and giving some table of protein and sending them after 10 days. So that is also putting a lot of drain of resources,
I think, sir, your point is very well taken. I think that is the message that that we are all understanding.
And let me tell you, more people have become positive in a so-called COVID-safe hospital. Our main Sir Gangaram hospital COVID-safe. But our more than 100 people, nurses and technicians, they have become positive, and mainly in this main hospital.
No,
Actually,
non-COVID.
not in the COVID hospital, they are not positive. They are quite all protected. Nothing. They are working very under hard conditions. Even then, they are quite safe and they are going home. There is hardly anybody has become positive in the COVID positive hospital. It is the COVID, so-called COVID safe hospital, which is our main hospital, where all these employees became positive. Either they are bringing infection from most of the infection coming from home, or they are not taking precaution while taking their lunch and breakfast at that time. They feel that we are all negative, so let us enjoy. And that way, there is somebody somebody positive, and that is how the infection is spreading. So this process, how will you stop? Even let us say you have seen Dr. Vivek was telling people are admitted with as COVID negative have undergone surgery after if they have gone positive. What is the answer for that? So I think somewhere, I don't know, we have to draw a midline.
Sir, have you started the transplant program also, sir?
We have done 5 transplants during last 10 12 days.
10, 12 days. So any adequate precaution you are taking for these major surgeries?
What adequate precaution you require? You require the
specific precautions.
I think anesthetics they must wear the PPE, proper PPE, and surgeon they also must wear. I don't know whether for many surgeries they require proper PPE, but so far I think they are wearing these good masks and protecting themselves, their face and eyes, quite okay for many surgeons. But anyway, we are providing everybody proper PPE to all, and everybody is being tested also for COVID against the government guidelines. So we are a private hospital, though government says that why we are getting the test done. We are not earning, we are not making any money in the COVID test, But for the safety of our workers, we are getting it done, against the BCs and guidelines of government and ICMR.
And any special thing which you will tell to small nursing homes, sir? How they should start functioning? And
I think around everybody, whether it's a doctor or patient or anybody, they have to think that you go with the attitude that everybody positive and take all universal precautions. That is how you learned how to live HIV, and that is how you learn with H1N1, and very soon you will learn how to live with coronavirus, COVID-19. Sooner or later, what is the answer? So galaxy of speakers is there.
No, I completely agree, sir. I think, as you rightly said, we discussed this in the earlier part of the panel discussion also, that we will need to be needing to learn to live with it and exercise universal precautions, because it is not very much practical to test each and every patient, and there is a limit to which we can keep the services at a lockdown. I firmly believe that in the while that around 4,000, 5,000 people we have lost because of Corona in the last 3 months, at least 10 times that number has easily died because of lack of services that we could provide to them, surgical services. As Dr. Vivek said, that people with acute emergencies are not coming for fear, and they're coming at a very late stage. And, so many emergencies which we used to do, where are they all gone? All our government hospitals, sir, we used to do 5-7 laparotomies every night. They've suddenly disappeared. They've not disappeared. These patients must be suffering and must be, finding their fate.
Yeah, they're dying at home.
Absolutely.
Arvind Kumar is sitting there, and you're all learned people as respiratory medicine is concerned. This virus, the proved route is only through your nose, mouth, and eyes, So even if you are testing somebody body, and even if somebody negative today, he is likely to become positive also after 5 days, 6 days. And anyway, there is no transmission through blood,
Yes.
So all of us take universal precautions, especially anesthetist, who is intubating a patient and extubating a patient, They say that this is irrespective thing, he may be potentially positive patient. So that is what we have to do, and that is what we have to learn. The question arises only whether people are very much afraid that whether they will get COVID in the hospital. So many of my patients ask that should we undergo surgery during this period or after this period. Whether if you can wait for 1 year, you may wait, but otherwise, whether you go today or after 6 weeks, there will not much change.
Very, very important points that you have raised here, sir.
All of us start working, and this much apprehension, which has been created by the media and everybody, which was maybe right actually, but now we have to take it off, from the heads of people, that you have to live with it and have universal precaution, whether it be patient, whether it doctor or any ordinary citizen or whosoever it may be.
Pawan, can I just highlight one point from
Yes,
what
sir.
Dr. So Professor Rana has actually given a very, very strong and a very practical and a very relevant message when he stated that, Gangaram is having two hospitals, City Hospital and Colmet Hospital, which are pure COVID hospitals. And the main building is actually non-COVID hospital. And as sir mentioned, that very, very few or negligible staff members have become positive in the centers which are managing COVID patients, whereas many more staff members have become positive in the hospital which is managing non-COVID patients. And there lies a very important message that actually if we lower our guard in practicing the precautionary measures, that's where the problem is going to occur. Sir has given, by revealing this figure, he's actually given a very, very important and strong message that in the next few months till this problem settles, doing universal precautions, presuming every patient to be positive and taking as much practical precautions as possible, that's going to be our guiding principle. Over to you, Pawan.
Yes, Arvind, I would just like to sum up that, hello?
Yes, sir.
I think we stop using term COVID negative. There is no even single hospital in the world which can be called that it be COVID negative. You can, at the maximum, you can say COVID safe. In every hospital, single hospital, you will find somebody or else becoming positive now. So that is all.
Thank you, sir.
Thank you very much, sir. Thank you.
Thank you, sir.
For coming with us here,
Thank
sir.
you, thank you everybody.
Very
And
kind
thank
of
you,
you, sir. Very kind of you.
And,
Thank you, sir.
where is Raghu? Raghu has gone or is there?
Yes, sir. Raghu has gone, sir. Dr. Raghu has gone, sir.
Thank you.
Okay,
Thank you, sir.
Sorry,
Dr. Raman Goel, sir, with you, because you had made the consent for COVID a very important part of your guideline. And what are the specific points you would like to highlight in this era of COVID about the consent for surgery?
So shall I share it on the screen if you want?
Yes, sir. Yes, sir. Yes, sir.
All right, just give me 1 minute. Okay, so this is basically not this one. Do you have the guidelines with you? 1 second. Yeah, it's here.
Yes, sir.
So this is from the inter-association guidelines, which Dr. Pavninder was mentioning, that all the three associations came together to form the guidelines. And this consent is a common consent between three associations. But, as we go through this, please realize that consent is more of a logical thing. So one is that we are talking about that the surgeon should accept that the patient should accept that it is happening when the surgery is happening when there is a pandemic. And then the hospital patient is aware of the risk and side effect of COVID-19 infection and precautions being taken. Then also the patient acknowledges that the hospital or the surgeon is taking all the following the guidelines given by the government and various bodies that are. So the dynamic of recovery is different than in a normal surgical patient if COVID by chance happens. And then he understands the implication and give consent for continuation of treatment or surgery. So patient may require extra investigations after surgery. and that he has been tested, even if he has been tested and found negative, he may become positive in the post-operative period if he is in a carrier stage. So this is I think a very important declaration, that this makes sure that the patient acknowledges that it is possible that he himself may be a carrier. And if I have not been tested, and if he agrees to continue with procedure and if found positive later, I would not attribute it to the surgical procedure, because again, he may be a carrier, and testing has not been done, as it is not allowed in many states. And as a lot of us discuss now, that testing is not really relevant because you have to go for universal precautions. So I think these are the key points. And I've explained that there is evidence that surgery is infected, but asymptomatic patient is associated with more severe disease if there is a COVID infection in these patients, and there is a heightened mortality. So I think these are the issues, but every surgeon should think about this consent and may add few more points. And one of the things that I believe in writing a consent form is that you should think what the patient wants to know, what the patient is apprehensive about, and take precaution from that, because just following an association guideline is not but this gives a structure on which you can add one or 2 points and go with the consent. So this is what I feel is important.
Thank you, sir. Dr. Arvind, sir, a question to you. What are the types of PPE for intraoperative use? And will you like to guide all these our delegates and our faculty?
Yeah, so Tarun, there are 3 different types of PPEs which are now. PPE means when we're talking of PPE, the components are, first there is an overall, which is like a gown, and then you have foot covers, then you have of course the mask is there, N95, and then there are goggles, and then you have the face shield, and there is a full head cover, and then you have the nitrile gloves. So this is, and of course there is always a disposal bag which comes with this set. So this is what constitutes a complete PPE set. Now, depending on the thickness of the cloth and the kind of stitching, there are 3 different grades available. So as far as surgery is concerned, we recommend that type 3, which is the highest gram per square meter kind of a GSM cloth that should be used. More important than that, it is important that the areas where the stitching has been done, either it should be done in a manner that the stitching doesn't open, or a tape should be there. So you can have a special kind of stitching where it's not knitting, it's actually, it doesn't open up, or you have a tape. So these are things which you need to check. More important than what type of PPE you're wearing is whether you are wearing it correctly or not. I see people doing mistakes a lot of time in wearing a PPE in a proper manner, and then same way after you have done the surgery, the PPE needs to be removed, which means doffing. So most important is that the donning and the doffing, the areas have to be separated, and this has to be done in a proper way that you don't infect yourself. As was mentioned by Dr. Rana, if the precautions are taken properly. Yes, so you have shown this picture. Now this mask which you have shown, Tarun, so if you start from the bottom, you see the shoes are covered nicely with the shoe cover, and then there is an overall which is covering the whole body, including the face and covering the entire neck. It's important that the neck is also completely covered. Nitrile gloves are there. There is a N95 mask. This person is also wearing a face shield. Now what here he's wearing is a special kind of respirator mask, which we people, we are doing chest surgery, which is a much higher level of aerosol generation than the rest of the thing. So there are these masks available which actually give a much higher level of protection than the typical N95, but also have a flip side that it makes the work of breathing too much, and it also leads to CO2 retention. So after 3.5 hours of surgery, you actually start feeling very giddy kind of thing, and you have to de-scrub and breathe normally. There is another motorized mask which is available, which actually has a motor and which provides a kind of a special air environment around your face. I'm not showing it here. I have not started using it in the hospital, but it's available and we've seen it. So this is what constitutes a PPE, which protects you from the aerosol present in the theater. It has to be donned properly in the way that it should be described, and there are enough videos available. I cannot go into the specific details. So donning has to be done properly, and after you've come to the theater and you've done the procedure, the doffing, which means removal, because all the surfaces now are potentially infected. So I want to convey that this is the time where a large number of people do mistakes, and despite having worn a PPE, by wrong method of doffing, they actually end up infecting themselves or infect their colleagues if they are doing it together. So one, it needs to be done separately. Donning and doffing areas need to be separate, and there's a specific procedure which needs to be followed, and each one of us should actually see the correct videos and follow. We give a lot of stress to type of PPE, and very sadly, the people tend to neglect the method of donning and doffing. So Tarun, I want to stop by saying that of course PPE is crucial, but more important then is, it's like, you can have the best instrument or a best equipment, but if you don't use it properly, you will not make proper use of it. So donning and doffing in a correct way is very important. Tarun.
Tarun, I would like to say that a lot of points from our discussion, which we have kept in the, your list, may have been covered. So we will just quickly go over those points which have not been, which have not been touched so far, because we're already about 1 hour and 45 minutes into the webinar, and so we will also have some questions which we have answered on the Q&A. There are some things which are there from the audience also on the chat box. So please see the questions which are pending, which have not been covered, some areas which have not been covered. Your audio has to be unmuted, Tarun.
Dr. Pawan, do I have your permission to sign off, because I have to go for another webinar?
Yes.
Yes, sir. By all means, thank you very much for your kind presence, sir. We are grateful, sir.
Thank you.
Thank you.
Thanks to all of you.
Tarun, you have to unmute yourself.
Yes. Ma'am, Dr. Manisha, ma'am, what is this concept of positive pressure, negative pressure, and what is the air exchange which should be there in the OT?
Okay, yeah, the COVID OT has its specific, requirements. The basic principle is that the contaminated air which is present inside the OT should not leak out of the theater. And on the other hand, so that the spread of infection is prevented. And also the viral load inside the OT should be decreased so as to protect the team which is working. So most of the OTs, existing OTs, have a HVAC system, which is a positive pressure system, in which which is mainly based on recirculation of the air. So now for the COVID OTs, to mitigate both these problems, what we need is a negative pressure OT, which is a non-circulatory type. So for this, you need, the AHU should be able to supply a lot of fresh air, 12 to 15 air exchanges per 24 hours. And then you should have powerful exhaust, which can, exhaust the contaminated air out of the OT. And the rate of exhaustion should be much more than the rate of supply of air, so that you create a negative pressure of at least 5 pascals. And this exhausted air should be, before being vented into the atmosphere, should ideally be treated by various methods like the UV radiation, heating mechanisms, application of HEPA filters. And for cooling your OT, for maintaining its temperature, you can have standalone air conditioners, which along with recirculation should have intake of outdoor air. 12 to 15 air exchanges should be there. And the temperature should be set between 24 to 30 degrees centigrade with a relative humidity between 40 to 70%. And you should ensure that the air which is being exhausted, the exhaust should be at the head end of the patient, which is the area of maximum viral load. And there should be no leak in your exhaust system.
Thank you very much, Dr. Manisha. These were very important points. At this time, I'm thanking Dr. Raman Goyal. He has to leave for another webinar. So thank you very much, sir, for being here.
Yeah, thank you so much. It was going so well, and I was really enjoying the information input and the controversies that we addressed. So thank you so much.
I have one question to you.
Yes,
Specifically,
Tarun,
just
Tarun
ask before going. Precautions during laparoscopic surgery, which is specifically for laparoscopy and IGs, I would like you specifically say a few points.
So Tarun, basically what is happening is that it's an evolving situation. First 1 month, we were told that laparoscopy should not be done. Every surgery should be an open surgery. Then gradually realization came that you can do a short surgery laparoscopically, like acute appendicitis. It is better in an obese patient, do it and get out rather than doing an open surgery. And now the situation is evolving, saying that laparoscopy is better than open surgery. So I think any guidelines at the moment, but as far as precautions are concerned, I completely agree with you that there are some poor evidence, but there is some evidence that the pneumoperitoneum may have COVID infection in it. So when you are desufflating the abdomen, it can contaminate the air in the operating room. So there are many devices like HEPA filters and ULPA filters from big companies, and there are many jugards which have been done by surgeons in India. Do you have a video which you can play?
Yes, sir. We just.
So the issue is those jugards. Initially, we were very critical, and in our first guideline, we actually wrote down that any innovation should not be done because we were not sure how safe it is. It has been published now, and we can see this. We can hear the doctor explaining this. So we believe it's safe. It's a ICD. Can you increase the volume? So it's a ICD which has a 10% hypochlorite solution in it, and it is connected to the trocar. So this particular trocar is used to desufflate the abdomen, and the CO2 along with the smoke goes into the ICD bag, and the outlet of the ICD is connected to a HEPA filter through a T-tube connector. So you use a T-tube connector and you connect it, and then the outlet of this HEPA filter is connected to the suction machine. Now this surgeon has very nicely shown using a foot controlled suction, but you know, this is commonly used even now in peripheral parts of our country where electricity may not be available all the time. So you can connect it to any suction machine, and then it shows that when you're desufflating, the air bubbles through the hypochlorite solution, then it goes through the HEPA filter, and then it goes into suction, and the suction outlet can be placed outside the operating room. So there is double or triple protection. You're bubbling it through hypochlorite, then HEPA filter, and then suction outlet goes outside the operating room. So I think doing all this, but I must say the other way, we have reviewed the evidence that has come. That's extremely poor evidence that pneumoperitoneum will have COVID virus. There are 1 or 2 case reports. We have done a meta-analysis. We have seen of 14 reports and some poor evidence, but I'm not saying that you take any chance because, you know, your life is precious and life of everybody in the operating room is precious. So I think these are the kind of things that can be done. Besides, obviously, speaking less, speaking at a low volume, as Dr. Manisha was saying, even talking at high volume is known to create more CO2 in the more virus load in the operating area, and taking smaller incisions so there is no leak by the side of the trocar. But you know, whatever you do, ultimately when you change the instrument, some amount of CO2 will come out. So I think the protection is the N95 mask. And one of the things that I saw and which I found very funny is last two pictures that you have shown. In both of them, the surgeon was not using a goggle. They were using their normal glasses. I think goggle is as important, a tight fitting goggle is as important as N95 mask, because the face shield doesn't filter the virus. The virus can go by the side and can go into your conjunctiva. So a tight fitting goggle and an N95 mask is absolutely must for everybody in the operating room, irrespective of what role they play. And on top of it, a face shield to prevent a splash and viral load is another thing. But basically, those are the precautions that we need to take.
Thank you, sir. Thank you, Dr. Raman Goyal, sir. And you can take a leave. We are obliged that you accepted our request. Thank you, sir. From Delhi State Chapter and Dr. Lal.
Bye-bye.
Thank you. Thank you very much, sir. Thank you for being with us.
Take care. Take care. Thank
Dr. Ujjwal?
Yeah.
Dr. Ujjwal?
Yeah.
If any patient comes out post-operatively positive, what are the specific things or what are the protocol which should be taken if that patient post-operatively becomes positive?
See, those for patient point of view, there is nothing different that you need to do. But from the people who are exposed point of view, then you need to have a very strict contact history, and then you need to keep a watch on those people. The guidelines, they are changing every day, whether we need to quarantine those people who are exposed to these patients or not. They are changing every day. Reason is that it's an evolving knowledge, and with the evolving knowledge, the fear, slowly and slowly, the fear is also going away. The fear that we had in the first 100 cases that we had in India is not when we have 150,000 cases. So as the fear goes away, in the same way, the reason to quarantine people will also go away. We just need to keep a watch on the symptoms of whether the patients are becoming or the contacts are becoming symptomatic or not. That is what we can do with every precaution that we are taking in the hospital. Everybody needs to wear a mask. We need to wear our protective gears. We need to maintain social distancing. We need to keep hand hygiene. That is what we need to do.
Thank you. Thank you. Dr. Manisha, ma'am, any specific advice for OT in nursing home setups, ma'am? Because they don't have this laminar flow, they just have a window AC or a split AC. What specific precaution these nursing homes should be taking?
If you are, operating on such a patient whom you consider as COVID, then you must have, an exhaust system in place, an exhaust fan, powerful exhaust, which can, help you to exhaust out your air, and simple measures of treating the exhausted air, even if you do not have HEPA filters or UV radiation, is that the duct should be placed at least 3 feet above the highest point of the building, so that it is, vented out quite at a height into the atmosphere. Then you can put split ACs for cooling your OT, keeping the temperature to 24 to 30 degrees, and the doors can be kept a little bit open to allow intake of fresh air. Though it does compromise, on your sterility of the OT, but that's the least, a makeshift arrangement that can be done. Of course, you cannot do away with the proper doffing areas which have to be created, whether it's a nursing home or a big hospital. You can't do away with such things, at least.
Thank you, ma'am. Dr. Ujjwal, we would like to talk about HCQ prophylaxis for healthcare workers. What is the yes, no, contraindications, precautions to be taken, and how long to be continued?
Well, the answer is no and yes. No, because the international studies that have been done, so-called studies that have been done, have not shown any benefits of HCQS use in patients who are patients, as well as there are very little information about the prophylaxis. Yes, yes. There is very little information about the prophylaxis. Yeah. But whatever information that we have about prophylaxis, especially in India, and I have heard yesterday somebody was informing me that the ICMR or the ministry has also written to the WHO that in prophylaxis it has a role, and they have seen that those patients, those people who have been given prophylaxis, the severity of disease is much less and the mortality is much less. So if we have to follow the guidelines, then we should, all the healthcare workers should be taking HCQS, provided they do not have any risk factors which predispose them to the any adverse effects of HCQS. This is one. But at the same time, it is an optional thing. It is an optional thing. You can't force people to take this, but you can only suggest that if you wish to take it, you take it. Because as far as I am concerned, there is very little information which says that yes, prophylaxis is very effective in this. I do agree that it's a very short period of time where we can put these kind of studies into any kind of statistical analysis. But at present, we do not have any clear-cut guidelines which say that this is beneficial or harmful. And about the harmfulness, there are a lot of our rheumatologists, people who are making people aware that it is not as risky as having side effects that has been said in the literature or publicized all over the world. But as far as prophylaxis I'm concerned, I am taking it. Reason is that when I started taking it, the ICMR was strongly saying that all the healthcare workers should be taking it. And then I'm also taking round of those COVID hospitals. So I'm taking that and I've continued to take that.
And how long to continue?
Initially it was said that you need to take it for 7 weeks. But now they say that after the end of 7th or 8th week, you get an ECG done, evaluate yourself again, and if everything is okay, you can again continue taking it.
400 mg weekly.
Yes, 400
mg weekly. So now we can take the question. Dr. Lal, do you feel that we should take the questions from the...
Yeah, I think there are, thank you very much. And now I think there are a few questions. I would first invite Dr. Anil Agarwal is there online. He is Director Professor and Head of GI Surgery at GV Pant Hospital, and is also the current Director of GV Pant Hospital. So I would like to ask him, because he had come up with some questions, and so I think since he is online, it will be nice for him to join and give his viewpoints. Dr. Anil, please.
Yeah, good evening, Pawan, and it was a really learning exercise, an excellent webinar, and thanks for the organizing team. And I just wanted to make a couple of points. One is about, a lot of times when we talk about testing before surgery, it is kind of thought of as that probably it is to only safeguard the healthcare workers. But as Dr. Arvind, alluded to in between, that this Wuhan study that he was alluding to had a 20% mortality, and there was a high morbidity in those which were COVID positive. And in fact, 100% of them had pneumonia. 15 of the patients out of 34 went to ICU. So I think what the issue is, like the point that you also made, that universal precautions, yes, because there are false negative. So all patients that you operate, even if they are negative, you think that probably it might be positive, so you have to take universal precautions. But where this will help you, the testing, is that if there's a surgery which you can avoid till the time the patient becomes negative, then you can postpone that non-emergent surgery. So that is one point. And there are a few other studies also which have been published in April and May. So I think that is one point. And because every time the administrators would tell us that, oh, are you trying to safeguard your healthcare workers? But it is actually in the interest of the patient that he goes in with a COVID negative report. The second thing is about what Arvind was talking about, the PPE. I mean, one thing I think maybe he mentioned, forgot to mention that word, because it's not just the GSM thickness, it's also laminated or non-laminated, because, even if it is a thicker thing, but if it gets wet, it seeps through. So it has to be a laminated, and even in that, you have two qualities of laminated PPEs which are coming. I'm talking about the high-risk areas like the ICUs or the OTs and other things, where you would be directly in contact with such patients. And in those, in fact, the laminated is the one in which, so I think ideally they've talked about that at least it should be 50 plus 20 GSM, 50 of the non-woven material and 20 millimeters to 70 mm. But those, I think, guidelines keep changing. But the idea is, and laminated outside is better than laminated inside, because laminated outside, you sweat less if it is not on your body. So that's one thing. And just the last point is about, this business about, actually nobody really knows, because what you need is a negative pressure OT, because we have always been talking about positive pressure OT. Negative pressure OT, I think negative hospital, then New York or somewhere there is one hospital that they had made earlier. But otherwise, now you are only trying to make attempts to convert the existing OT into negative pressure OT by putting the exhaust and other things. Because classically, when you talk about a negative pressure OT, means that your inflow which is coming, and like the laminar flow, and the vent is at the lower level. Because I am always scared about that if an exhaust is at the higher level, and if it is churning the particles or the viral particles which are settling down, I would be afraid. So I think the vent has to be at a lower level. So these things, you have to keep it in mind. We shouldn't, in our overzealous thing about having a big exhaust there. And I would be worried as a surgeon or as a caregiver in an ICU, if those settled particles are kind of taken away in front of my breathing area and all. So I think just these few points I wanted to make. Thank you very much. But excellent webinar and a learning exercise.
Thank you, Dr. Anil, for those very important points. Actually, we are all learning. Even those who are making the guidelines don't know what all to keep in the guidelines and when to bring which one and when to withdraw the other one, because things are all evolving at such a pace and new data is actually emerging at a very fast rate. And as Dr. Vatil said in the beginning, that all the reports that are also coming, we have to take with a pinch of salt. But at this point, when you are talking about doing the testing of patients, and someone actually remarked that if you don't do the test and when you release him and discharge him, you also don't know what his status is at the discharge time, whether he's positive or not. What about if I say the patient says that, are you, doctor, are you positive or negative?
Dr. Ujjwal, can you take this?
Hello.
I think the simplest answer to this is that we all should have a Arogya Setu app and we can show it to each other.
Sorry, have a test done, is it? That's what you said?
No, I said that we should all have a simplest answer is we should all have a Arogya Setu app with us and we should show each other that yes, our status is clear.
Arogya Setu, yes. Okay, yes, that's a good point. We had not talked about it so far, but I think that's important. And if there are any questions from any of the people who are there online, I think Dr. Podar wants to join in. Dr. Podar, please.
Hello, Dr. Lal.
Yes, Dr. Pavninder. Hello.
Yeah, Dr. Podar, speak.
Yeah, if a patient of gallstone has history of pancreatitis in say 2 months back, so will this lab chole you consider as routine or it will be a semi-emergency sort of thing?
Yeah, so I think if there is if the patient has had a history of pancreatitis, then of course it is in a resolving state, and we could consider this as an interval cholecystectomy unless the patient is actually being in the phase of acute pancreatitis. And as we have already discussed, we have to take that call of whether the patient needs the emergency surgery at this time or we have to defer it, at a later time depending on the condition of the patient. So I think that point has already been discussed.
No, what I meant, patient has multiple gallstones. Suppose he again develops pancreatitis, then he will blame you. Why you didn't do surgery?
I think that is actually the gray zone. You have to take the call, and as of now, it would stay as an interval cholecystectomy only. It cannot be classified as an emergency. But of course, if there are repeat attacks, the patient has to be informed, and that is where the consent comes in. With the consent that we shared, is very protective. It protects you as a surgeon. It also informs the patient that if you are going in for this surgery, you know that you are likely to, you are at a risk of a procedure and you will be hospitalized. So all the risks of that hospitalization of having, and if there are other comorbidities, they will all be adding up to the whole situation. Dr. K.N. Srivastav, is there any comment from your side?
Well, I would say it has been excellent webinar and I myself learned a lot. That is one. Secondly, one question was that suppose, is there any medical legal issue? Suppose if you are using a routine filter after laparoscopic surgery, or you are using a jugaad, which we have already seen, which is equally effective, it appears. So I just wanted to know about the medical aspect of using a, described filter, which costs about 10,000 per patient. So that was the main issue which I wanted to ask the panelists.
I think sir, medical legal issue would not be there much because it is for our protection, not for the patient much, because we are considering him as a positive, and anyhow these machines cost more than 4 lakh, 5 lakhs, and then the consumable is also there 4, 5, 7, 10,000. So if cost is not an issue for a hospital, they can buy it. But I think these are equally effective and good solutions for these, sir.
Medical legal, I meant that, anesthetists as well as the the OT staff, technicians, because they are also exposed to the.
Yes, sir.
So that was the issue.
Dr.
I think I agree with you.
Hello, Dr. Tarun.
Yeah, Dr. Vasanti. Yeah, speak, ma'am, please.
Very nice webinar, and I think ASI Delhi State Chapter has really come of age. Started off with our monthly meet, and now this one, very beautiful. Regarding the negative pressure OTs, I'm given to understand that in Singapore and other places, it's a routine, particularly for cardiac transplants and all that. In fact, the advice is that, post-operative also, if possible, we should have negative pressure areas in the wards and things like that. But I'm not sure if anywhere in the private or in the government sector we have in our country. That is one thing. And the other thing is, do we have, Dr. Parminder Lal, COVID-free pathways? Because LNJP is treating a lot of COVID patients. And the other day when I was speaking to Dr. Anil, he was saying that the Delhi government has issued orders that cancer surgery and all should not be stopped. And so elective surgeries are going on for cancer surgery and other things. So how are you managing?
So ma'am, at our hospital, it's completely COVID, and we have got different blocks. So we have got all of the blocks. Once you enter, then you have got areas, and there are no corridors as such within the block, because in the block, then you will start doing the duty. You need to reach the ward. So common corridor, which is the staircase and all, is the common area. When you enter the specific floors, floor-wise, then of course, you enter the positive area where the patients are located, and then you have the donning and the doffing for each floor, and likewise for each block. Unfortunately, we are at the receiving end, and I'm not sure whether this has been a good decision or bad decision. About 1,500 undergraduate students, 750 postgraduate students, and around 500 faculty members are not in a position to conduct any teaching, research, activity. It has all come to a standstill, and we have created about 1,000 beds, where we have about 6,000 beds in 200 bedded 30 government hospitals all over the city. Whether this was a good idea to take it in a large teaching hospital of this size, I'm not able to reconcile with it. And but it has been the decision, and now they've all declared that this is going to be it. So as far as teaching and routine surgery is concerned, routine procedures are concerned, routine training for postgraduates is concerned, everything has taken a backseat at our institution, which is the leading institution in the country, in the city today, alongside other institutions, but ours is completely to a standstill. So we are not in a position to, we are not doing any elective procedures. We are not in a position to do them at all. Unless some policy change takes place at the higher level, I'm afraid we are only going to be a COVID hospital for the next couple of months.
True, but also in a way, see, though with all its negative side, but I think for residents in particular, this is a lifetime opportunity to be exposed. And later when they come into administrative positions, with this exposure, perhaps they may be able to manage it better. We would never want to have another pandemic, but in the event, it happens, say 30, 40 years from now, when they are administrators, with this experience, they would probably have an exposure and be in a better position to manage it.
Dr. J.B. Agarwal, sir, you have a question? Dr. Jugal, sir? Dr. Jugal sir, are you there?
Yeah, I'm there.
Yes, sir.
Can you hear me? Can you hear me?
Yes, sir. Yes, sir.
I also want to make some few comments.
Yes, sir.
See, about HRCT, when you are doing an emergency surgery and you are doing a CT abdomen, I think it is very easy to do a HRCT at the same time, which will give you some guidelines about whether the patient is in a COVID position or not. Because the specificity of HRCT is quite good and it does not require any preparation and it gives you immediate result much before the PCR report comes. So I think doing a HRCT when you are doing CT abdomen, I think it's a good idea to do so as to safeguard yourself and the patient as well.
Any questions that you want to ask?
I want to ask one question. The suction which you are doing. Hello.
Yes, sir.
The suction which you are doing and the material which goes into the bottle, suction bottle, what precautions do you take?
Dr. Lal, sir?
What precautions do you take to safeguard your healthcare workers which are transmitting that sucked material from one bottle to the discarded area? Suction material from suction.
So as of now, in the emergency OTs where it is working, the suctions are being cleaned, then they are washed, and then ultimately sodium hypochlorite and alcohol-based solutions are used to clean them. And that's about it that is being done, because these are all to be used in a reusable fashion. However, the tubing is being used separately, new tubing is being used separately, which comes from the patient to the suction machine. That is the routine that we do as such also. But the tubing within the suction and the suction bottles per se are cleaned as in normal case. But the additional part, what is being done is that the sodium hypochlorite and alcohol-based solution is being used to rinse the bottle, wash it and put it back again. That is about it, because there is no other way to, we don't have the luxury of throwing away the, the bottle or having a disposable system for these suctions.
Can I make a comment here? There is a system which is available from Japanese company, which is a separate suction bottle. And at the end of it, when the suction bottle is full, there is some activation of chelating agent which freezes the whole bottle, and the whole bottle can be discarded. I think it's a very, very safe method. I have seen a demo of it and I was really impressed by that technique.
Thank you, sir. There was a question to Dr. Manisha. There was a question which I was in one of the Q&A or a chat session, that is it advisable for patients to have betadine gargles before coming to surgery? Would that reduce the viral load in case the patient has to have? So if you say had a betadine gargle at night and come in the morning, does that affect? I mean, I had never heard of that, but it's a random question.
Cannot comment. I have no idea. I have not read it, so I can't support. I have not seen it.
I don't think it is recommended, sir. I don't think it is recommended.
Yeah, I think, and the only thing someone had used about the betadine use as antiviricidal, I think the only thing that has been recommended varicidal is the 70% alcohol solution, base solutions. These povidone iodine has not been shown as a varicidal as such. So,
I think one question to Dr. Ujjwal: if we by chance come in contact with COVID patient or our colleague COVID patient, what should we do at our home and work, both? Dr. Ujjwal.
See, as it has been reiterated enough that we are going to live with COVID. So what we need to do is we need to keep a close watch on ourselves. We need to, if we are working in a hospital, then we are taking every precaution in the house that we do not transmit any kind of infection to our family members. So if we are coming back from the hospital, we need to take utmost care that we are disposing of our clothes in a proper manner. We are taking bath, we are cleaning ourselves and maintaining a good hygiene. That is what we can do. And as far as anything, I don't think I need to add anything more
HCQ,
into this.
Should we take HCQ?
See, that I've already told that it's an optional thing. I am taking it. Others have the option of taking it. I don't have any proof to say that it is effective, but I'm taking just because I started taking 8 weeks back. And since I'm seeing these patients on a regular basis, I continue to take. but that's an optional thing. And I don't think there is any reason to start if we have a contact and we start this medicine. It is not like a prophylaxis that can be taken after exposure.
Thank you. So any questions specifically anyone want to ask, please? Can ask Dr. Lamba, Dr. Rana sir, Rana Iki Singh sir. Anything?
Arun, I can only say that it has been a fantastic, very informative. I was glued to this speaker right from beginning. I mean, probably I joined it before even it took off, and I benefited immensely. Thank you so much. Thank you, Dr. Pranindar Lal, and whole of the executive committee of Delhi State Chapter of ASI. Thank you so much.
So we would like to say closing comments, Dr. Chand Vatal sir. Would you like to say anything?
Thank you very much for this opportunity. Yes, it was nice to be amongst the surgeons who usually say that they are riding a bicycle. And but then the interpretations as they are, I am very sure and very glad that quite well informed the team that was here, very well informed team, and taking the right guesses. And the very fact that you discharging patients, so that is actually more than half done. And when they go home, only tell them that keep safe and keep on using mask all the time. And mask is even Czech Republic. They were the first to come under the curve completely, and they used masks. That is what they did. Every household was making masks and masks in scores. And right from children till adults and the elderly, they all use only masks primarily. And they just simply finished their pandemic as they had. So we need to actually stress on the usage of masks, maintaining social distance. These are the two basic things that can keep us safe. Thank you very much.
Dr. Ujjwal, your closing comments. And also Dr. Maninder has asked about mask, what patient should be wearing, which type of mask patient should be wearing.
See, regarding masks, there are everybody is trying to take whatever kind of precaution he can take. But I would suggest that for general public and for people who are not taking care of these kind of patients, a surgical mask is good enough. If I am a healthcare worker, if I'm doing a surgery, or if I'm taking care of the patients or coming very close to these kind of patients who have a potential of getting infection, then N95 mask is required. But sadly, general public is using N95 mask without thinking whether they need it or not. And secondly, since it is very costly, they are using it every day. One mask, they're using it for a week. They're pulling it down, pulling it up every day, 10 times, 100 times, 200 times they're doing it. I don't know whether this N95 mask is actually benefiting them or not. So what we need to do is, if we are a healthcare worker, we need to use these N95 masks regularly and properly. Proper use of these N95 masks is good, is what is required. We should have a very good seal around our face. We should test that whatever mask we are using has a very good seal, and whatever air we are breathing in is coming through the mask and not from the sides. This is what we have to ensure when we are using the mask.
Thank you, Dr. Manisha ma'am, closing comments.
Yeah, in this era of difficult COVID times, anesthetist and the surgeon should be in sync with each other and take combined decisions regarding which patient to operate or which patient should not be operated. Regional anesthetic, which involves central neuroaxial blocks as well as peripheral neuroaxial blocks, preferably ultrasound guided, should be the norm of the day, should be the choice of the anesthetic. And only the experienced anesthesiologist should be doing the actual intubations. We should use lots of newer gadgets like video laryngoscopes, which help us to keep away from the patient. Use of intubation boxes, face shields, plastic covers. All these help us, to keep ourselves safe and the whole team. So that's it. And we should remember that these patients do have post-op complications and may require ventilatory support. So we should be ready for it.
Thank you.
And COVID is here to stay.
Dr. Lambasa, you wanted to say something?
Dr. Mittal?
Yeah, ma'am.
See, now, according to the Italian study, in COVID patients, the main cause of death, they've said, is DIC. So would prophylactic aspirin be advised on these patients whom we operate or treat who are COVID positive?
Dr. Ujjwal?
Because they are going to be bedridden at least for a few days.
Dr. Ujjwal?
It is an inflammatory condition and it does cause inflammation, and there are reports that it causes microthrombi in the lungs. So therefore, there is a role of giving low molecular heparin to all the patients who are admitted with COVID. As far as post-operative care of patients is concerned, well, there are enough guidelines to say that any patient who is supposed to remain in the bed for more than 4 days should be getting low molecular weight heparin to prevent any kind of thrombotic episode happening.
Thank you. Thank you. Dr. Lal sir, closing comments?
Well, I would only say that a big thank you to all the panelists for being today, all the members, esteemed members of the Delhi State Chapter, our guests from Mumbai, Dr. Raman Goel, from Hyderabad, Dr. P. Raghuram, many other guests from other associations who had joined in, our esteemed panelists, Dr. Vattal, Dr. Ujjwal from Gangaram Hospital, Dr. D.S. Rana, Dr. Arvind Kumar, and all the senior esteemed members from the Delhi State Chapter. I would like to, just simply say that we need to continue this endeavor to communicate with each other through this new mode that we have got used to. 2 months back, we were not doing Zoom. Occasionally, we used to Zoom with our friends or families away from us. Now, this has become a norm. We are doing it several times. And I think we'll have to extend it to telemedicine as well. So with those words, and I would simply say thank you to the entire executive of our Delhi State Chapter, ably led by our very dynamic and versatile Secretary, Dr. Tarun, very ably supported by Dr. Vivek Bindal, Dr. Anmol for this particular webinar, Dr. Sumit, who has been a pillar for bringing out our newsletter, and all other senior members. A very big thank you, and we will assure you that we are going to come back with these seminars on and webinars on related topics frequently, but not making sure we don't give you an overdose at the same time, which it's already been 2 hours plus now. And
closing comments from Ujjwal and then Vivek also, because Vivek was the organizer.
Yes,
I just wanted to thank everybody, the organizers, for keeping 2 non-surgeons, me and Dr. Vattal, safe. Thank you very much.
Vivek,
yes,
thank you for helping us organize this, and your closing comments. Then we
closing comments. It was a wonderfully organized seminar, mainly because of the faculty, and their comments were very valuable. I think you chose the best people around in their fields, and I wish everyone.
Yeah. So a very big thank you to Dr. Manisha as well, who has been leading the ICU care. She's a frontline COVID warrior from the ICU perspective. For the last 2 months, they have been battling a very tense battle of, full ICU, new ICU being created, new equipment to be taken, very challenging situations in a government hospital. We all know how things work, how things are difficult. And hats off to you, madam. Thank you so much for coming in. And for all those who don't know, she's the better half of Dr. Anil Agarwal. So it was great that both of 2 webinars, two of you were there in the same webinar. So that's a first of its kind, I would say. So thank you so much. And thank you, everyone. Keep safe.
Stay safe.
Thank you very much. Thank you.
Thank you.
Thank you, Dr. Pavninder and Dr. Tarun. Very, very
Thank you.
Thank you, sir.
Thank you.